Good morning, ladies and gentlemen. I must sincerely apologise that I'm not able to be with you today in Munich. I had really looked forward to being at this meeting to help FECAVA celebrate its 20th Congress. I was privileged to be a speaker at the first FECAVA Congress in Paris in 1994, so it really would have been great to be there in person to celebrate this anniversary. However, despite my absence, I really wanted to be sure that you were able to receive the presentation that I prepared for this meeting. This morning, we're going to talk about how to work up a case of hypercalcemia.
Perhaps hypercalcemia is something you come across quite often, or perhaps it's a very rare circumstance in your clinical practice. Hopefully, we'll spend some time this morning working through how to work up hypercalcemia in a way that you'll find helpful and logical. So consider a case such as Morris, a 12-year-old female husky who arrives with a complaint of polyuria, polydipsia and lethargy. But on clinical examination there was really very little to find. When you investigate further by laboratory methods, you might find a negative urine glucose, a normal plasma creatinine, a normal white cell count, things that you would generally look for in a polyuria, polydipsia investigation. But you may discover that urine-specific gravity is inappropriately dilute and that there is an abnormal or elevated plasma calcium. This is the kind of circumstance that you may be faced with and that we hope to address this morning. So we're going to talk a little bit about how calcium is normally controlled, what can go wrong in that process to cause hypercalcemia. We'll talk about when we should be sure that calcium is measured as part of our routine laboratory work. We'll check whether to believe the patient really is hypercalcemic, including what else we need to measure, whether we need to measure ionized calcium, whether or not something that looks like hypercalcemia really is hypercalcemia. We'll spend a few minutes on how urgent the investigation is, what the first step should be, what the next step should be, and what available further investigations there are. So how is calcium normally controlled? It's important to realise that calcium within plasma and the ICF is maintained in a very narrow reference range. It's very tightly controlled. Almost all calcium in the body is stored in the skeleton, with a small quantity available in the circulation and the rest of the tissues. Calcium generally comes in through gastrointestinal absorption, with only a small amount of losses through the intestine. Calcium gets into the urinary filtrate, but almost all of it's reabsorbed, so there's a very small amount of calcium losses through the kidneys. Vitamin D is also a very important molecule to consider in this process. That also comes from dietary sources or might be the result of UV action on the skin in certain species. When that vitamin D gets to the liver, it's hydroxylated to form 25-hydroxycholecalciferol or calcidiol. This vitamin D intermediate is then further processed in the renal tubules to become the active form of vitamin D, otherwise known as 1,25-dihydroxycholecalciferol or calcitriol. And that's accomplished by the addition of another hydroxyl group in what's described as 1-alpha hydroxylation. Parathyroid hormone is a very important part of the process also. So parathyroid hormone is capable of reducing calcium clearance by the kidneys. It's capable of promoting calcitriol production in the renal tubules. Calcitriol increases then to cause an increase in the absorption of calcium from the intestine, and also calcitriol exerts an effect on bone. Parathyroid hormone directly acting on bone can promote bone turnover and net resorption of calcium from bone. And this combination of reduced calcium clearance by the kidney, calcium uptake or release from the skeleton, calcium uptake from the intestine all serves to increase or promote plasma calcium levels. However, there's a tight negative feedback control from those ionized calcium levels back to the parathyroid gland to control those PTH outputs. So in this process, what can go wrong to cause hypercalcemia? Well, we might have increased parathyroid hormone activity, that would be the diagnosis of primary hyperparathyroidism. We might have increased activity of parathyroid hormone-like substances, which is what we will see in cases of humoral hypercalcemia of malignancy. There's a particular molecule called parathyroid hormone-related peptide that's able to have this effect. There might be increased vitamin D activity coming in through diet or through a dietary toxin. There might be granulomatous disease. That's important because mononuclear cells are able to cause increase in the 1-alpha hydroxylation, so they can cause increasing levels of calcitriol. There might be local destruction of bone, often through a neoplastic process, and that osteolytic process releases calcium into the circulation. And there are some other unclear mechanisms by which we see hypercalcemia, but no doubt we do see them. So Addison's disease, hypoadrenocorticism that is, we see it in feline idiopathic hypercalcemia and in grape and raisin toxicity. We might also see it in angiostrongylus infections, which is missing from this slide. What then would be our principal differentials for hypercalcemia? Well, it's easiest really to consider grouping these by conditions that are parathyroid dependent versus those that are parathyroid independent. So parathyroid dependent causes would include parathyroid adenoma, adenocarcinoma, hyperplasia. By far the most common of these would be parathyroid adenoma. In other species there is a genetic disorder which causes a calcium sensor defect. It causes familial hypercalcemic hypocalciuria, not yet reported in dogs and cats, so a theoretical possibility to be on the lookout for. Parathyroid independent hypercalcemia would include humoral hypercalcemia of malignancy, vitamin D excess, granulomatous disease, osteolytic conditions, hypercalcemia, idiopathic hypercalcemia in cats, Addison's disease. And we also need to consider those other differentials like grape and raisin toxicity. So malignancy is quite a big category, and within that we would need to consider lymphoma, anal sac apocrine gland adenocarcinoma, other carcinomas which could be bronchial, renal, gastric, squamous cell carcinomas, and pretty much any solid carcinomas capable of this action. Multiple myeloma, osteosarcoma, metastatic disease of any neoplasm into bone, and histiocytic neoplasia. So they would be the top of our malignancy list. Thymoma is a much less common possibility also. Vitamin D excess can take the form of oversupplementation, where somebody thinks they're doing good by giving their animal extra vitamins. It can occur through incorrect dietary formulation at a manufacturers who's making a commercial pet food. In the US and outside Europe, it's possible to have vitamin D excess because there are some vitamin D based rodenticides. There are human medications to treat psoriasis, which are vitamin D analogues, and they come in the form of creams or ointments, product names like Dovabet or Dovanex. There are some plants that have vitamin D action, and granulomatous disease, as I mentioned, is capable of the 1-alpha hydroxylation to create calcitriol. So those are the kind of things that could go wrong to cause hypercalcemia. When should we ensure that calcium is being measured? So most laboratories these days offer panels of biochemistry tests, and many of those will include the measurement of calcium. There may be some panels that don't routinely include calcium, and so it's important to be aware when calcium really should be included in one of those chemistry profiles that you send off to the lab or run within your clinic. This is a list of some presenting signs of hypercalcemia, and you can see polyuria, polydipsia, vomiting, anorexia, muscle weakness, dehydration. And clearly more significant or clinically obvious conditions like lymphadenopathy, rubber jaw, or osteopenia or consequences of urinary calculi such as calcium oxalate would be much more specific reasons to measure calcium, but you can see that particularly in an internal medicine scenario within your veterinary clinic, the need to measure calcium is pretty common. When we get a result back, having measured total calcium, we need to try and understand whether or not that really represents an abnormality. So it's useful to know the laboratory method that you use. Does it sometimes give false high calcium results? Is it worth retesting any high calcium results by that same method when you receive a high value just to confirm that it's genuine? Is it worth sending that sample somewhere else or having a different laboratory method used to confirm hypercalcemia when it's suspected on the initial result? So you're going to know that or get some experience of that by using your most familiar routine lab method. It's also important to know whether or not the methods that you use can get high calciums due to lipemia, icterus or hemolysis. Clearly getting the best quality of sample is the ideal situation, but there are circumstances where despite our best efforts there will be a problem with the sample, and it's important to know whether that's going to affect our calcium result. And some of you may already have experienced that some dry chemistry analyzers can occasionally generate elevated calciums or calciums slightly outside the reference range, which then after that sample is submitted to a reference lab, those results cannot be reconfirmed. So how does calcium travel in the circulation? When we measure total calcium by that routine laboratory method, we are measuring the sum of three different fractions. We're measuring an ionized calcium portion, a bound calcium portion, and a complex calcium portion. Ionized calcium can be thought of as the free or physiologically active form of calcium. This is the form of calcium that's going to be free to interact with tissues. It's the form that's going to exert negative feedback effect to the parathyroid gland. Bound calcium is calcium that's connected with or circulating in association with albumin. And complex calcium is calcium circulating in association with anions such as phosphate, lactate, citrate, those kind of things. So it's really important that we consider albumin because so much of the total measured calcium is associated with it. There may be circumstances where we measure a low total calcium because albumin is low and therefore the bound calcium fraction is low. But in these cases, ionized calcium may be completely normal. So the first thing we do when we see a low ionized calcium, whenever we see a low total calcium, is to check whether or not the albumin is low, because that may be the explanation. In the converse, where we have a high calcium, it's still worth having a look at albumin to see whether or not we have a high, low or normal albumin result that might influence our interpretation of that. We also need to consider phosphorus and some uremic anions, in that it is possible when there's an increase in the presence of phosphorus that phosphorus takes some ionized calcium from the free ionized pool and complexes it to increase the complex fraction. What that can result in is an increased complex fraction contributing to an overall higher level of total calcium, but in which the physiologically active form of calcium, ionized calcium, has in fact reduced. So this creates the unusual situation of having a high total calcium, which doesn't mean physiologic hypercalcemia, because in fact we may indeed only have a low ionized calcium and that physiologically the animal is hypocalcemic. So it's useful to know that ionized calcium can help us in that situation. So that situation is most likely to arise in cases of renal secondary hyperparathyroidism. This is a process mediated through FGF23 and decreased calcitriol production and reduced calcium absorption. All of those together result in an increase in parathyroid hormone production. That hyperphosphatemia can also bind out some of that free ionized calcium, reducing the ionized fraction but increasing the complex fraction. That could create a high total calcium or normal total calcium, but the ionized calcium in these advanced, particularly in the advanced cases, are likely to be low or low normal, and we will be able to measure a high parathyroid hormone in these cases. It's useful once we've got to the stage of deciding that we do indeed have a hypercalcemia to understand how urgent the further investigation needs to be. We've already touched on the fact that the law of mass action means that calcium and phosphorus, as their concentrations increase, that increases the likelihood that they combine, precipitate or complex. If that happens in tissues, we get soft tissue mineralization, which can cause organ dysfunction. That's most likely to happen in the kidneys, the gastric mucosa, but sometimes in other tissues. We can attempt to predict whether that's likely to happen by calculating the calcium-phosphorus product. Unfortunately, there's some variation in the literature as to at what point we should consider a significant risk of mineralization, but in the milligram per deciliter units, we'd expect anything from 60 or in some cases 50 milligrams per deciliter squared to be associated with an increased risk of mineralization. In millimoles per litre units, it's more in the region of 4 to 4.8 as a ratio. For example, animals with vitamin D intoxication will tend to have both elevations in calcium and phosphorus. So the calcium-phosphorus product will be high, and the case therefore will be urgent. Animals with primary hyperparathyroidism, whilst they have hypercalcemia, they tend to have low or normal phosphorus concentrations, making the calcium-phosphorus product less likely to be associated with a risk of mineralization, and therefore the investigation and the management of the case is less urgent than in the vitamin D intoxication example. So what are going to be some of the first steps in our investigation? Well, if we start just by reviewing the history, we want to know if the animal's being given any vitamin supplements. We want to know if it's receiving an unusual or an unfamiliar brand of commercial pet food. That's to try and cover the possibility that an incorrect dietary formulation has been made at the pet food manufacturer. However, to be honest, some of the occasions that this has happened in the past have involved major pet food brands or popular pet food brands, so it wouldn't be something you would rule out just because the brand is familiar to you. It can be a difficult thing to detect. Michigan State University in the US receives lots of parathyroid hormone and calcium samples from around the country, and so for them it's relatively straightforward to spot if there is a significant batch of pet food in the marketplace which is causing hypercalcemia. In Europe that's not so clear cut. We have much more diverse routes through which lab samples go for calcium and parathyroid hormone investigations, and so it's harder for the labs to pick up when they're seeing an increase in these cases. But diet, whether that be a popular brand or an unfamiliar brand, is an important consideration. We need to think about the possibility of grape or raisin toxicity. Is there any history of access to those? Is there access to other types of vitamin D in the form of perhaps human supplements in the home, rat poisons, admittedly outside the EU, psoriasis medication like Dovanex or Dovabet, or certain plants. We would also want to review the signalment. Primary hyperparathyroidism really is a middle-aged to geriatric age disease. There is one breed of dog, the Keeshond, which is predisposed, and in that breed you can see it in slightly younger dogs than in general, but generally it's an older dog disease. And here's just something that emphasises that. This is based on some data from Michigan State University's PTH and calcium service, and we can see that the cases of primary hyperparathyroidism, we don't really start to see very many until we get to 6 or 7 years of age, but really it's a disease most commonly affecting 9 to 13-year-old dogs. On the contrary, animals with primary animals with hypercalcemia of malignancy or results consistent with that tend to be younger. So investigations to try and separate hypercalcemia malignancy from primary hyperparathyroidism are very useful in this age range, but down here they're less useful. The diagnosis of primary hyperparathyroidism is quite uncommon in these younger animals. We've touched on breed already. Here's just a list of the most common breeds identified in that Michigan State database, and you can see that Keesond is right at the top and very overrepresented compared to other much more common breeds in the population like Golden Retrievers and Labradors. So the odds ratio against the general breeds is something like 50, so certainly a very clear predisposition. That's been identified by Dr. Goldstein, who was at Cornell, as an autosomal dominant process. A gene has been identified with a mutation which now allows Keesonds to be tested through a genetic test for predisposition at Cornell Vet School. So we've reviewed the history in this case of hypercalcemia. We've kind of looked a little bit at the lab results. What else are we going to do in terms of clinical as a next step? We're going to really review the clinical situation in its entirety. We want to re-examine the lymph nodes, all those palpable lymph nodes we need to recheck, perhaps consider imaging for any internal lymph nodes. We want to, again, in the dogs at least, review for the possible presence of anal sac masses, including perhaps imaging the subnumber lymph nodes. We want to hunt down any other masses that might represent a neoplastic or granulomatous process, and we want to rule out angiostrongylus. So we've reviewed history, reviewed the clinical findings. Next of all, we want to review again our lab results. We want to make sure that we've got an ionized calcium result. We need albumin to understand how that's impacting on total calcium measurement, and similarly phosphorus. Recently, somebody looked again at whether or not the chloride to phosphorus ratio can be helpful, and they found that it was highly specific for primary hyperparathyroidism and anal sac tumours, but it had a low diagnostic sensitivity, but that's something which, if that's very high, it might be helpful. Urea creatinine and sodium potassium ratio, that can urea and creatinine is helpful both in helping us understand whether there's any renal dysfunction there that we need to consider in our interpretation, and also whether or not Addison's disease is a possible differential. And similarly, sodium potassium ratio would be important in cases where we're considering Addison's disease or need to consider Addison's disease. So we can use the combination of some of these findings to help us get a little bit further. So in cases of parathyroid hormone or parathyroid hormone related peptide excess, we can expect hypercalcemia with low or normal phosphorus. In cases of vitamin D excess, we'll have hypercalcemia, but often an elevated phosphorus. And in secondary renal hyperparathyroidism, although total calcium might be high, ionized calcium will generally be low or normal, and phosphorus early in the process might be normal, but late in the process will have increased. And that's not an uncommon situation that we're asked to help with. So in situations where we have azotemia and we have a high total calcium, we need to try and figure out which came first. Is this a case of renal dysfunction causing elevated total calcium, or is this a case of elevated total calcium causing damage to the kidneys and a consequent azotemia? The most simple way to address that is to measure ionized calcium. So in cases of renal dysfunction being responsible for the observed elevated total calcium, then ionized calcium is likely to be low or normal. Whereas if elevated calcium is causing renal dysfunction, we can expect to find an elevated ionized calcium. So having taken it as far as we can in terms of clinical review, history taking, and our routine lab tests, we might want to consider moving on to more specific endocrine diagnostic tests. right at the beginning, we broke our differential diagnoses down into those that are parathyroid dependent and those that are parathyroid independent. And we can see that in both of those situations we can expect to have hypercalcemia, obviously, but in the parathyroid dependent we expect PTH concentrations to be the cause of that, whereas in parathyroid independent we expect that whatever's causing that hypercalcemia should, through negative feedback on the parathyroid gland, cause a low PTH. And this is a handy way to think about interpreting those combinations of test results. So if we look at this chart, if we have animals with high ionized calcium and PTH which is in the low part or is subnormal, then we can be quite comfortable that that's parathyroid independent hypercalcemia, and that could be hypercalcemia of malignancy or a vitamin D intoxication or a granulomatous disease process. Primary hyperparathyroidism is going to be a much more likely diagnosis when we have PTH that's elevated or in the top part of the reference range. It is important to notice that hyperparathyroidism does include cases in which PTH is within the reference range but within the top part of the reference range, because we would expect through negative feedback ionized calcium elevations to reduce PTH. The failure to reduce that to the bottom part of the reference range would support the presence of primary hyperparathyroidism. Unfortunately, we do recognise a grey zone where PTH results landing in this area are difficult to interpret, and we can't clearly differentiate primary from parathyroid independent causes. So having categorised our case as parathyroid dependent or independent, the next further investigation is usually because we've identified parathyroid independent hypercalcemia. Clearly, if we've identified parathyroid dependent, should be a parathyroid adenoma or possibly adenocarcinoma, and that requires imaging, ultrasound or surgical exploration. So the difficulty really only arises when we have parathyroid independent hypercalcemia. That's the combination of a low PTH and a high ionized calcium with no initial clinical appearance of neoplastic processes or granulomas. So tests that we consider in these situations include parathyroid hormone related peptide, 25-hydroxyvitamin D and 1,25-dihydroxyvitamin D. So what is PTHrP? Well, it's a molecule which is identical to PTH at its N-terminal. It's a different size molecule otherwise, but in that most N part of the molecule, the 1 to 34 range, it's identical to PTH. So it can exert the same function as PTH and have that same effect on raising ionized calcium concentrations. It's present in many instances of humoral hypercalcemia of malignancy. The disadvantage is it's very labile and susceptible to loss during shipping. If we get a positive result, that's very helpful, but clearly partly because we lose it in shipping and partly because some tumours don't secrete it, if we get a negative result, that doesn't completely rule out hypercalcemia of malignancy. So here's just a couple of publications emphasising that, one by Richard Mellenby looking at PTHrP in dogs, one by Anne Provencher-Bollinger looking at PTHrP in cats. We'll talk about some of the tumour types that Richard looked at in dogs. In cats, it was a much less common finding PTHrP positivity, and in general the cases tended to be more carcinomatous than in dogs. So here's a graphic taken from Richard Mellenby's paper demonstrating that you can sometimes expect to see PTHrP positive in the hypercalcemic lymphomas and anocytic carcinomas. Occasionally you'll get negatives, but only relatively uncommonly will you get positive PTHrPs in primary hyperparathyroidism. So PTHrP can help us look for underlying neoplasia that we can't otherwise identify. 25-hydroxyvitamin D, that can be useful to us as an indicator of dietary sufficiency or excess. So if we've got cholecalciferol intoxication or dietary excess, this test will pick that up. Unfortunately, it won't detect analogues of vitamin D, so chemically altered synthetic types of vitamin D may not show up in this assay. In addition to being a useful tool for hypercalcemia cases, there's increasing recognition that measuring vitamin D can be useful for prognosis or risk in intestinal, cardiac and other neoplastic diseases. It's also a really good tool for measuring UV adequacy in those species that depend on UV light for their vitamin D. So for example, in these young growing green iguanas, we can see that adding dietary vitamin D to fluorescent lighting really doesn't do very much in terms of increasing the availability of vitamin D in the circulation, whereas having the correct lighting can generate very high levels of vitamin D in these patients, and in fact the addition of dietary vitamin D really does make no difference in those cases. Calcitriol, again, is something you can measure. It's a little harder to get measured than 25-hydroxyvitamin D, but it should be available. It's going to, or theoretically at least, it should be reduced in concentration when there's reduced renal tubular mass. The decrease in its production rate is implicated in the pathogenesis of renal secondary hyperparathyroidism. So as this is downregulated or produced less, either because of reduction of renal tubular mass or the effects of FGF23, then there's less calcium resorbed from the intestine, which contributes to the hypocalcemia, which drives the high parathyroid hormone concentrations we see in those patients. This method also won't detect any synthetic forms of vitamin D, such as the product or the calcipotriene, the product that's within Dovanex and Dovabet. And it might be useful in some cases of hypocalcemia investigations. So again, here Richard Mellenby has published on measuring calcitriol in cases with granulomatous disease. Feline idiopathic hypercalcemia is a difficult one because it is, as it says, idiopathic. Sometimes it presents with calcium oxalate urolithiasis. There has been a question mark as to whether or not this is associated with an increased feeding of acidifying diets. There is a paper which has suggested that feeding high fibre diets to these patients can help correct the hypercalcemia. Perhaps pedigree long-haired cats are more predisposed, and there's some debate as to whether or not this condition can cause progression to renal failure, and if there is a concern about that, whether or not treatment with glucocorticoids is the appropriate thing to do. So we've really covered the workup of hypercalcemia from the perspective of reviewing history, reviewing clinical presentation, reviewing routine lab results. If that hasn't got you to your diagnosis, looking at parathyroid hormone and ionized calcium as specialist endocrine tests, and if that still needs more work, moving on to parathyroid hormone related peptide 25-hydroxyvitamin D to see if that can take you any further. So I thought we'd spend the last part of this session just looking at some simple case examples of lab results. So these are scenarios which I would have experienced working in a diagnostic lab, so you need to forgive the lack of clinical information in these cases, but hopefully you'll recognize that just by looking at the lab results alone, you can take this quite far in terms of diagnosis and diagnostic confidence. So if we consider a 13-year-old female golden retriever with a high total calcium, a high ionized calcium, and a high PTH. If we think about our differentials of parathyroid dependent and parathyroid independent, is it clear what the mechanism is in this case? So if we look at the little diagnostic or interpretive chart, this is a case where ionized calcium is high, as is PTH. So we're landing quite comfortably in this box that says primary hyperparathyroidism. So we can be quite comfortable that this is primary hyperparathyroidism. If this was hypercalcemia of malignancy, we would expect PTH to have been suppressed through negative feedback from the high calcium that's coming from somewhere other than the parathyroid gland. So at surgery we might expect to see something like this. This is a Cairn Terrier, which might give you an idea of the scale here, and this is its parathyroid adenoma. That is an unusually large parathyroid adenoma. They're not always as obvious as this, but this was a very cool case. The parathyroid concentrations being secreted by this mass were sufficient to give this dog rubber jaw. So on radiographs of its mandible and maxilla there was a really very significant osteopenia, which following surgery dramatically improved and recovered within only a matter of a few weeks, which was really very impressive to see. Here's another example case of 14-year-old male Keysond, and this is a case with elevated total and ionized calcium. PTH in this case is not elevated, so we need to have a think about what this condition is more likely to be. Is this more likely to be parathyroid independent or parathyroid dependent? If this was parathyroid independent, we'd expect this high level of ionized calcium to cause suppression of parathyroid hormone production, and that's not happening. So that is suggesting that this is a case where we have autonomous tissue within the parathyroid gland, or most likely parathyroid adenoma. So again, looking at our little chart, if we look up here to the high ionized calcium range and we go up here to the high normal range for parathyroid hormone, again we're landing comfortably in the primary hyperparathyroidism box. So again, relatively straightforward diagnosis of primary hyperparathyroidism in this case. If we look at a 5-year-old golden retriever with a high ionized calcium, a low PTH and a positive PTHRP result, what is the most likely scenario in this case is in terms of whether this is primary hyperparathyroidism, parathyroid dependent disease, or parathyroid independent disease. So this high level of ionized calcium is successfully reducing parathyroid hormone production, which suggests that it's coming from a source other than the parathyroid glands. And we've also talked about PTHRP being positive, and when PTHRP is positive, we need to consider lymphomas, anal sac adenocarcinomas, and also other carcinomas or other neoplasia. So this is an animal with an elevated ionized calcium but a low PTH, which lands the animal in this parathyroid independent hypercalcemic category. And we need to differentiate between hypercalcemia of malignancy and vitamin D intoxication, which this positive PTHRP result has allowed us to do. What about if we look at a 3-year-old, another golden retriever, with a high ionized calcium, a low PTH, and a negative PTHRP? Can we determine whether this is parathyroid independent or parathyroid dependent? And once we've determined that, can we, if we think this is parathyroid independent, can we determine the source? So yet again, this high ionized calcium is suppressing that PTH appropriately. So we've got high ionized calcium, low PTH. This fits in the PTH independent hypercalcemic box. Unfortunately, this negative PTHRP does not help us differentiate between malignancy, vitamin D intoxication, and granulomatous disease, and that's because some of these hypercalcemic neoplastic processes do generate negative PTHRP results. So in this case, we're going to need to look further, perhaps with other imaging or sampling techniques. Perhaps if we have a concern about dietary access to vitamin D, we might want to perform a 25-hydroxyvitamin D test to see whether that is likely to be part of the problem. So once again, I'm really sorry that I'm not able to be present with you in Munich today to give this presentation in person. I hope you found the presentation useful and that you have gained something that will help you investigate the next hypercalcemia case that you come across. Many thanks for your attention.